Good evening, everyone, and apologies for this little delay. I would really like to welcome you to this new MP online session. My name is Alfonso Guaron, and I will be moderating today's webinar on ASH 2017 highlights in multiple myeloma. So, as part of MP educational program, this session has the aim of informing patients, caregivers, and advocates about the most recent findings in the field of myeloma that were presented during the last American Society of Hematology annual meeting, who took place in Atlanta in December last year. So the talk will be given by Dr. María Victoria Mateos from the Hematology Department of the University Hospital of Salamanca in Spain. So, Dr. Mateos, on behalf of Myeloma Patients Europe, I would like to thank you for your kind collaboration to provide all our attendees to this session with the most juicy news that came out from this Congress. So for your information, this webinar will be fully recorded and uploaded to the MP website, which is www.mpeurope.org. And just before we get started, I would like to give you a very brief overview on the webinar dynamics. So the first part of the session will last between 30 to 35 minutes, where Dr. Mateos will go through her presentation, and then after this presentation, we'll have some time for you to make those questions that you may have. So there are two ways in which you can do these questions. One of them is to make your question by voice using your microphone. So you just simply have to click on the raise hand icon, and I will open your mic so you can make your questions live to Dr. Mateos. You can also send the questions by writing using the chat box, and I will read them to the doctor so she can answer you. So without any further ado, I wish you all a very interesting and fruitful webinar, and I give you the floor, Dr. Mateos.
Yeah, hello, Alfonso, and so good afternoon, everyone. And I apologize for the delay, but so today is my clinic day, and so I finished just some minutes ago. So thanks, everyone, and apologize again. And Alfonso asked me to do a review about the most exciting results from ASH 2017, especially for you, for patients or caregivers or people involved in patients associations with multiple myeloma. So I would like to divide my talk in three parts, and the first one will be focused on smoldering or asymptomatic myeloma. The second one in newly diagnosed myeloma patients, no candidates and candidates to autologous stem cell transplantation, and finally relapsed and refractory myeloma. And starting by smoldering myeloma, you probably know that the smoldering myeloma includes asymptomatic multiple myeloma patients. And according to the last criteria published at the end of 2014, you can see that the definition of smoldering myeloma was updated, and the criteria for the definition of smoldering includes now the presence of a monoclonal component of at least 3 grams per deciliter, plus plasma cell bone marrow infiltration between 10 and 60%, but without any myeloma defining event. And probably you are familiarized with this patient population because you have to know that smoldering is a very heterogeneous disease. And within the same name, smoldering, we can identify patients at low risk of progression to myeloma, patients at intermediate risk of progression to myeloma, and patients at high risk of progression to myeloma. So the investigation is focused on these high-risk smoldering myeloma patients in order to try to plan early treatment, in order to see if the early treatment in asymptomatic myeloma patients at high risk of progression to myeloma could potentially delay the progression to myeloma. And this was demonstrated by the Spanish myeloma group some years ago, and in fact, so it was published in New England Journal of Medicine in 2013, when we decided to use lenalidomide and dexamethasone as early treatment for asymptomatic myeloma patients. During this ASH meeting, we had the opportunity to present the results, the preliminary result of another trial conducted by the Spanish myeloma group, the GIM CESAR trial, in which we included 90 high-risk smoldering myeloma patients and candidates to receive an autologous stem cell transplantation. And our objective with this early approach of therapy was not to try to delay the progression to myeloma, but probably to cure some asymptomatic myeloma patients. And for this objective, these 90 patients are currently ongoing, receiving induction with carfilzomib, lenalidomide, and dexamethasone, followed by transplant, consolidation, and maintenance with lenalidomide for up to 2 years. In summary, you can see that 100% of the patients responded to these combinations, but if we focus on the complete response rate, you can see that after induction, 43% of the patients achieved complete response, and this complete response rate increased at 57% after transplant, 75% after consolidation, and 90% of the patients that are receiving now maintenance are in complete response. But we decided, of course, to evaluate the quality of the response in terms of minimal residual disease. And you can see that the proportion of patients achieving MRD negative increased over the time, and after consolidation, 60% of the patients are in MRD negative. In terms of toxicity, I would say that the toxicity profile was very acceptable, and no major adverse events or serious adverse events have been so far reported in this trial. The median follow-up is very short, but you can see like most patients remain free of progression and most patients remain alive, so we have to wait a longer follow-up, but this presentation was interesting, especially because, as I previously said, this is a curative strategy for asymptomatic myeloma patients. And also together with this abstract, there was another presentation based also in asymptomatic myeloma patients, but in this case treated with daratumumab. And daratumumab, as you know, is the CD38 monoclonal antibody targeting CD38 that is present on the surface of the plasma cells. In this trial, you can see 3 different subgroups of patients that received 3 different schemes of daratumumab. One of them, the long arm, the intermediate arm, and the short arm, including the administration of only 4 doses of daratumumab. Anyway, the message that you have to learn from this study is you can see that not many patients achieved complete response after daratumumab single agent. However, when they decided to compare each of these arms with a hypothetically patient population of asymptomatic myeloma patients, in which the progression-free survival would be of approximately 2 years, the use of daratumumab as single agent resulted into a significant benefit in terms of progression-free survival. And in fact, you can see here the progression-free survival or the progression to myeloma, and you can see a significant benefit, especially for the long and intermediate arm. And in fact, the long arm has been chosen as a chemotherapy for the next phase 3 trial that is currently ongoing. From the safety profile point of view, tolerability was acceptable, and in fact, the findings were consistent with other single-agent daratumumab studies. And you have to know that there is currently ongoing a phase 3 randomized trial in which daratumumab is being compared with observation with no treatment in high-risk smoldering myeloma patients. So 2 oral presentations based on high-risk smoldering myeloma, one of them with a curative objective, with a curative approach, whilst the other, the main objective is to try to delay the progression to myeloma. Now let's move on to evaluate the new findings in the transplant-ineligible newly diagnosed myeloma patients. And you have to know that for this patient population, especially here in Europe, the 2 standards of care for this patient population are VMP or continuous treatment with lenalidomide and dexamethasone. In this case, during this ASH, we decided to select VMP as control arm, and one of the most interesting presentations done at a late breaking abstract and published at the same time in New England Journal of Medicine were the results of the Alcyone study. The Alcyone study is a phase 3 randomized trial in which 706 newly diagnosed myeloma patients non-eligible for autologous stem cell transplantation were randomized to receive VMP, the standard of care, or VMP plus daratumumab. And you can see that the addition of daratumumab resulted into a significant prolongation of the progression-free survival. But I would like to note how the benefit is observed since the beginning, and in fact the curves started to separate since the cycle number 1. When we decided to add daratumumab to VMP, we are going to reduce the probability of progression or death by 50%. And this benefit, in fact, is sustained across the different subgroup of patients and is derived from the high efficacy observed with VMP plus daratumumab in terms of overall response rate. And you can see that 91% of the patients receiving VMP plus dara achieved at least partial response, but the most relevant is the complete response rate, 43% versus 24%. And again, in this study, the minimal residual disease was evaluated, and you can see that approximately 22% of the patients in DARA VMP achieved MRD negative in the bone marrow versus only 6% in the VMP arm, and MRD negativity translated into a significant benefit in terms of progression-free survival, because as you probably know, MRD negative is an excellent surrogate marker predicting progression-free survival and also probably overall survival. From the safety point of view, the addition of daratumumab to VMP did not result in more hematological toxicity, did not result in more peripheral neuropathy or gastrointestinal toxicity, and only infections and probably pneumonia was the unique adverse event more frequently reported in DARA VMP versus VMP alone. However, it's true that most of this pneumonia resolved, and in fact, one patient in each arm discontinued treatment due to pneumonia. In addition, we evaluated also the infusion-related reactions, and you can see that only 1/3 of patients had infusion-related reactions, most of them during the first infusion and of grade 1 and 2. So I would say that in general, DARA plus VMP resulted very effective, always superior to the control arm VMP, with an acceptable safety profile. And the final message coming from the Alcyon trial is that DARA plus VMP will be a new standard of care for the treatment of elderly patients with newly diagnosed multiple myeloma. And also in the treatment of elderly patients with newly diagnosed myeloma, there was also an interesting meta-analysis conducted by the Italian myeloma group in order to see what treatment is much more effective for patients with high-risk cytogenetic abnormalities, VMP or Lendex, or bortezomib-based combination or lenalidomide-based combinations. And the message is something that we've already known, that bortezomib or VMP resulted more effective for patients with high-risk cytogenetic abnormalities, although I have to say that probably the ideal treatment for high-risk patients with myeloma would be the combination of both proteasome inhibitors and immunomodulatory drugs. Now, let's move on to focus on the transplant eligible, on the young, newly diagnosed multiple myeloma patients. And again, this is what we can consider the standard of care for transplant candidates newly diagnosed myeloma patients. And these patients usually receive the induction, transplant, followed by maintenance. And if we follow this scheme, first, the Spanish myeloma group presented the results of induction with VRD 6 cycles in a series of almost 500 newly diagnosed myeloma patients. And you can see that VRD 6 cycles resulted in a complete response rate of approximately 40%. Most importantly, when this patient received transplant, the complete response rate increased up to almost 50%, and this patient received subsequently consolidation with 2 cycles VRD, and the complete response rate increased up to 60%. We did a comparison between VRD and our standard of care until now, that is VTD. So we decided to replace thalidomide by lenalidomide, and the replacement of thalidomide by lenalidomide resulted especially in a significantly decrease in the peripheral neuropathy rate. What is important, especially for the patients, because with this combination, the frequency of peripheral neuropathy is extremely low. So this is also important. Another studies presented at last meeting were focused in order to continue evaluating if a young newly diagnosed myeloma patient has to receive autologous stem cell transplantation, yes or no. And the European Myeloma Network updated the results of his phase 3 trial, in which transplant was compared with VMP after induction with Cy/Boti. The final message is, as you can see, that transplant is superior to no transplant in terms of progression-free survival. Although it is true that in terms of overall survival, there is not any significant benefit yet. However, we have to know that the median follow-up right now is of approximately 3 years. So probably we have to wait a longer follow-up in order to see if there is finally benefit in terms of overall survival. But anyway, in terms of progression-free survival, transplant resulted superior. And in addition, the superiority of transplant versus consolidation, in this case with VMP, is sustained in patients with high-risk cytogenetic abnormalities, in patients with deletion 17p, and in patients with ISS3, so in patients with advanced stage of the disease. So the final message and the conclusion would be that for young newly diagnosed myeloma patients, we have to consider transplant as the standard of care after induction with 3-drug-based combination. And also, a subject of debate that probably you have heard sometimes is the role of double transplant. So is there any specific patient population in which we can proceed to a second transplant after the first one? And again, the European Myeloma Network responded to this question again with this trial, and this was presented by Michele Cabo, and I would say a clear message: tandem autologous stem cell transplantation benefit to those patients with high-risk cytogenetic abnormalities. You can see here single versus double transplant in patients with high risk, and double transplant was superior. And when we compared tandem transplant, we selected the patient population who received tandem transplant and compared the outcome between standard and high-risk cytogenetic abnormalities. The outcome is exactly the same, indicating that tandem transplant is able to overcome the poor prognosis of the presence of high-risk cytogenetic abnormalities. The same in terms of overall survival, and I think that there is a clear message that tandem transplant should be prescribed or should be offered for patients with high-risk cytogenetic abnormalities. As you know, the standard of care for autologous stem cell transplantation, the standard conditioning regime is melphalan 200 milligrams per square meter. And the French group tried to evaluate if the addition of bortezomib to MEL 200 can result of benefit. And the answer is very simple: no. It is not necessary to add bortezomib to high-dose melphalan, because there is not going to observe any benefit in terms of complete response rate, in terms of MRD negative, and in terms of progression-free survival. So the standard of care as conditioning regime continues being MEL 200. What about maintenance? You know that the European Medicines Agency approved in June 2017 lenalidomide single agent as continuous therapy for transplant-eligible myeloma patients after autologous stem cell transplantation. The approval was based on a large meta-analysis, including the results of 3 phase 3 randomized trials, and during this asset, the English group, the MRC group, consolidated these results with a large series of patients, almost 2,000 newly diagnosed myeloma patients, in which you can see that the use of lenalidomide as maintenance after transplant resulted into a duplication of the progression-free survival, 20 versus 40 months. So this is a clear message, and this consolidated the role of lenalidomide as a standard of care after transplant for all young newly diagnosed myeloma patients. In addition, the MRC group evaluated also the role of MRD negative, with again the same message. Some patients receiving lenalidomide as maintenance were able to convert the MRD positive into MRD negative, and of course, always patients who achieved MRD negative had a significant benefit in terms of both progression-free survival and also overall survival. And in fact, following with the minimal residual disease, there were two important oral presentations based on the minimal residual disease. The first one is coming from the Spanish myeloma group, the series of patients, the almost 500 patients receiving induction with VRD, transplant and consolidation. And it's very clear, you can see in green, patients achieving MRD negativity, in this case for next generation flow, and you can see that the outcome is significantly better in comparison with those patients in which the minimal residual disease is positive. So this would be an important endpoint in order to reach by the maximum number of patients as possible. And these results has been also confirmed by the French group with a similar study with a different design, but again, VRD as induction, followed by transplant or consolidation with VRD maintenance with lenalidomide, but the message is that the patients who achieved minimal residual disease negative had a significant benefit in terms of both progression-free survival and overall survival. So you have to know that so authorities are in the process of approval the MRD as endpoint to be used in the clinical trials, and you have to know that the clinical trials conducted by the different cooperative groups here in Europe and also probably in the US considered as primary endpoint the minimal residual disease negative by next generation flow or next generation sequencing. It doesn't matter. The most important thing is to try to reach MRD negative because it's an excellent surrogate marker. And now let's move on to evaluate the relapse and refractory myeloma. And you have to know as patients that so the landscape for the treatment of relapse and refractory myeloma patients is really challenging. And so this is probably a busy slide, but it's just to put in context that when one myeloma patient is in first or even subsequent relapse, but probably in first relapse, the different options of therapy are, as you can see here, many different combinations, and the choice is going to be influenced by the first line of therapy. And you know that most of our patients are now receiving lenalidomide as part of the first line of therapy, and this is going to influence for sure the option at relapse. But anyway, we have here four new three-drug-based combinations based on lenalidomide, dexamethasone plus something else. These three new based combination that we can use for our patients at first relapse. The first one is the ASPIRE study, that this is a trial, a randomized trial in which carfilzomib, lenalidomide, and dexamethasone was compared with lenalidomide and dexamethasone. And the results of this trial were already published in New England Journal of Medicine in 2015, but in this meeting, Dr. Stewart from Mayo Clinic presented the final analysis of this trial, and what is relevant is the benefit in overall survival. So we already know the benefit in terms of progression-free survival, but now we know that the use of KRD in relapse and refractory myeloma patients translated into a benefit in terms of overall survival. There were also another presentations based on, for example, carfilzomib, and the English group evaluated the role of carfilzomib plus cyclophosphamide and dexamethasone in comparison with bortezomib, cyclophosphamide, and dexamethasone. And this is a phase 2 randomized study, but you can see that carfilzomib, cyclophosphamide, and dexamethasone is superior to Cy/Bort/D in terms of overall response rate and also in terms of complete response rate. But I would say that this combination seems to be especially effective in patients with high-risk cytogenetic abnormalities. Anyway, the follow-up of this study is short, and we have to wait in order to know how the progression-free survival is in both arms. And probably most important has been the update of the results of the POLLUX study. As you know, the POLLUX is a phase 3 randomized trial in which daratumumab, the CD38 monoclonal antibody, was added to lenalidomide and dexamethasone and compared with lenalidomide and dexamethasone in relapsed and refractory myeloma. The median follow-up now for this study is almost 3 years, and you can see that the benefit for DARA, lenalidomide and dexamethasone is sustained, and in fact the median progression-free survival has not been reached. The hazard ratio is 0.44, and this means that if you receive the DARA plus RD, you are going to reduce the probability of progression or death by 56% in comparison with the lenalidomide and dexamethasone alone. And this benefit is sustained or is derived from the efficacy in terms of overall response rate, 93%, but look as 55% of the patients receiving DARA plus RD achieved complete response, and approximately 1/3 of them, again, minimal residual disease negative. So the outcome for these patients in complete response, and especially in MRD negative, is going to be extremely good. In addition, the benefit of DRD is observed across the different subgroup of patients, even in patients with high-risk cytogenetic abnormalities. And the other phase 3 randomized trial based on daratumumab, but in this case in combination with bortezomib and dexamethasone, was also updated at last ASH meeting. And again, you can see that the addition of DARA to bortezomib and dexamethasone resulted into a significant benefit in terms of progression-free survival, median progression-free survival of 16 versus 7 months with a hazard ratio of 0.32. The benefit of this combination is going to be especially observed in patients after just one prior line of therapy, so in first relapse, and I would say that this in this place in which patients have to receive DARA plus VD. It is possible to use this combination also after 2 or 3 prior lines of therapy, but the benefit is not going to be so evident. So this would be the clear message. DVD very effective in patients after just one prior line of therapy. Come back again to this scenario, to this general scheme in which as most of our patients with multiple myeloma now are receiving lenalidomide in the upfront setting as part of maintenance after transplant, or lenalidomide and dexamethasone as continuous therapy for the non-transplant eligible myeloma patients. So we have to generate new combinations around proteasome inhibitors or even around the second generation of immunomodulatory drugs like pomalidomide and dexamethasone. And in fact, we had the opportunity to see an abstract in which pomalidomide and dexamethasone was evaluated in patients after 2 prior lines of therapy, and lenalidomide as the last prior line of therapy. So no so heavily pretreated myeloma patients. And although the number of patients is not very large, only 56 patients, you can see that the progression-free survival is of approximately 10 months. And in addition, another combination is based on pomalidomide, bortezomib, and dexamethasone. And you can see that this combination in no so heavily pretreated myeloma patients resulted in an overall response rate of almost 90% with 22% of complete response rate. This combination is especially effective in patients with deletion 17p, and you can see that the progression-free survival is of approximately 14 months. So this combination is relevant, especially because there is a phase 3 trial comparing VD plus minus pomalidomide, and the results of this trial probably will be presented at any congress during this year, and probably this will be a new standard of care for relapsed and refractory myeloma patients, pomalidomide in combination with bortezomib and dexamethasone. And pomalidomide and dexamethasone is also to be combined with the daratumumab. In this pilot study, only 40 patients, but you can see that the overall response rate is much more higher, approximately 73%, and 25% of them achieved at least a VGPR. The median follow-up is short, and we don't know yet the progression-free survival, but again, there is a phase 3 trial currently ongoing in Europe, comparing PomDex versus PomDex plus daratumumab, and probably we will have also a new standard of care for relapsed and refractory myeloma patients, PomDex plus daratumumab. And another possibility is to combine PomDex with cyclophosphamide and conventional alkylator of oral administration or IV and weekly, but you can see that POMA plus POM plus cyclo and dexamethasone is effective. In no so heavily pretreated myeloma patients, approximately 90% of the patients responded to this combination, with more than 1/3 of them achieved at least VGPR, and with a good safety profile. And again, these combinations based on pomalidomide and dexamethasone, and this would be the message, are moving to earlier phases of the disease, and probably we will start to use pomalidomide and dexamethasone in some cases, even after just one prior line of therapy. But for late advanced stage of the disease, especially in Europe, we continue using pomalidomide and dexamethasone as a single combination. But in this slide, although it's a busy slide, the message is that when we combine POMDEX with cyclophosphamide, daratumumab, selinexor, isatuximab, filanesib, novel agents, in late advanced stage of the disease, look like the number of prior lines of therapy is in all of them between 3 and 4. So many patients had received up to 9 prior lines of therapy, 9 or even 13 prior lines of therapy. So heavily pretreated myeloma patients, you can see that almost more than 50% of them can achieve at least partial response, and the progression-free survival is approximately the double in comparison with pomalidomide and dexamethasone alone. So we can continue using pomalidomide and dexamethasone also in late advanced stage of the disease. We can consider also the use of daratumumab single agent beyond the second or third relapse, and a single agent, daratumumab single agent, demonstrated to be effective, and I think that there are some patients for which we can continue prescribing daratumumab single agent. We will have other CD38 monoclonal antibodies like isatuximab or MOR202, but they have not been approved yet, and no new data were presented during last ASH meeting. Concerning other new agents for subsequent relapses, there is venetoclax as monotherapy, and venetoclax so is a targeted therapy because this drug is especially effective in myelomas with one specific translocation 1114, or overexpression of BCL2. And so venetoclax as monotherapy in this combination resulted very effective, 40% of overall response rate, and during this ASH meeting, only 20 additional patients were included in this trial in combination with dexamethasone, and you can see that the overall response rate was of approximately 65%. So this drug is really effective in these patients with translocation 1114. Melflufen is also an interesting drug that probably, I don't know if you know it or not, is a new alkylator, so is similar to melphalan, similar to cyclophosphamide, but different because it seems to be more potent. And 2 abstracts were presented based on melflufen, always in heavily pretreated myeloma patients, but especially in the second study, in which patients included were those patients already refractory to pomalidomide and refractory also to daratumumab. So patients after a median of 6 prior lines of therapy. And in this situation, approximately 1/3 of the patients responded. And in fact, we have a lot of experience with this agent, melflufen, in heavily pretreated myeloma patients. And it's important to note like the quality of life and the myeloma-related symptomatology, the bone pain, significantly improved with this drug. So we have to wait what are the final results, but just in case to know that melflufen is an agent that probably can be incorporated to the treatment landscape of our myeloma patients. And finally, let me show you probably interesting findings based on the new strategies of immunotherapy also for myeloma. And we had the opportunity to know results for new monoclonal antibody, conjugated monoclonal antibodies. This is an example, is one monoclonal antibody with a cytotoxic agent. So when the monoclonal antibody targets the plasma cells, in addition to different mechanisms that result into the killing of the plasma cells, a cytotoxic agent that you can see here, I don't know if you see my arrow, so this cytotoxic agent contributed to kill the myeloma cells. So this mechanism of action is extremely attractive for the treatment of myeloma patients. And 1 year ago, at ASH 2016, 30 patients, so a first abstract was presented with 30 patients and with promising results. But in this phase 1 trial, in this first part presented more than 1 year ago, we know that the maximum tolerated dose was 3.4 milligrams per kilo. During this ASH meeting, we had the opportunity to know the results of the second part, in which 35 patients were included, receiving the maximum tolerated dose, 3.4. You can see that more than 50% of the patients had received at least 5 prior lines of therapy. Most of them proteasome inhibitor refractory, IMiD refractory, DARA refractory, and in this situation, 60% of them responded, and in fact, some patients achieved complete response. So this monoclonal antibody, this conjugated monoclonal antibody, resulted in a median progression-free survival of approximately 8 months. These results are extremely important, and in fact, FDA designed at the end of this year this monoclonal antibody as a breakthrough therapy, so probably it will be approved very soon for relapsed and refractory myeloma patients after prior treatment with proteasome inhibitors, IMiDs, and monoclonal antibodies. And also, if we continue with the new immunotherapies for myeloma, we have to focus on the cell therapy, and I will show you one slide based on the CAR T cell. At least 1, 2, 3, 4, 5 abstracts, and probably more, were focused on CAR T cells for myeloma. First, you have to know the number of patients, and the number of patients included in this study are rather small. However, when we look at the efficacy, you can see that the patients with myeloma, when they received these CAR T cells, did not respond. All of them responded, 94%, 100%, 100%, with a significantly higher proportion of patients achieving MRD negative complete response, and in addition, MRD negative. These efficacy results are, of course, very encouraging. We have to take care about the toxicity because a proportion of patients can develop cytokine release syndromes, and you can see that the rate of patients developing cytokine release syndromes can be from 10 up to 50%, depending of the different type of CAR T cells. You have to know that all these CAR T cells target BCMA, that is an antigen also present on the surface of the plasma cells. This is an example of one CAR T cell evaluated in patients with extramedullary disease, and you can see that the plasmacytoma here in the skull as well as in the jaw significantly decreased just 1 month after the CAR T cell infusion. So the message for the CAR T cell is that they clearly represent a very encouraging and exciting therapy. You have to know that there are many clinical trials ongoing. They will arrive to our patients from Europe over this year in 2018. So we are excited by offering these new options of therapy for our patients with multiple myeloma here in Europe. But so we have to be also cautious, and we have to carefully evaluate the toxicity profile. But I think that they will definitely arrive to the treatment of our patients with multiple myeloma. And just this is the last slide, and this is just to show the natural history of the disease. Probably myeloma remains as an incurable disease, although I think that through the early treatment, through the MRD as primary endpoint, I think that we are going to offer the cure to some patients with a newly diagnosed multiple myeloma patients. And as physicians, we have to have in our mind always that we have to try to offer the best, the first for our patients with myeloma, because they are going to obtain the maximum benefit. And I will finish say that imagine when the CAR T cells are extremely safe and we can potentially prescribe CAR T cell for newly diagnosed myeloma patients, and with just one infusion, we can potentially cure myeloma patients. This would be our dream, But now I think that the situation is exciting because so we have a lot of new combinations, and this is going to allow us as physicians to prescribe the options of therapy for our myeloma patients in a more individualized way. And so we are going to put on the table patients' characteristics, patients' preferences, social characteristics of the patients, and I think that each patient can be treated with a tailored therapy. And I think that these would result, of course, in a more significant benefit for each patient as well as their families that they have to support to the patients. And here I finish. And if you want to, so I am open to answer your questions.
So thank you very much, Dr. Mateos, for this very comprehensive presentation and for sharing with us this very exciting news in myeloma. It seems that we are keeping winning the battle against this disease. So I have received some questions from you by writing. I just remind you that in case you want to make a question by voice, you just need to press the raise hand button, which is in the left part of your screen, and I will open your microphone. But or you can also test me some questions, and I will pass them to Dr. Mateos. So I will start with this. The first question, which is quite related with this last slide, and says, based on all these exciting discoveries presented at the Congress, and taking into account that this might not be a yes or not question, would it be possible to say that there might be a certain group of myeloma patients that can be cured, or do you think that myeloma will become more a kind of chronic type of cancer which will recur over longer periods of time?
So this is a difficult question, and so I think that to convert the myeloma into a chronic disease, I think that this would be a reality, not for all patients, but a significant proportion of patients. And so we have now patients in our clinic surviving for more than 10, 15 years because so they are able to receive different lines of therapy, including drugs with a different mechanism of action. So this can be exciting because so at the end you are able to prolong the survival of myeloma patients, and I would say that this is a reality. However, when we talk about the cure of the disease, I think that we have to focus on asymptomatic myeloma patients at a high risk of progression to myeloma, or newly diagnosed myeloma patients of standard risk, of course, because for me patients with high risk features are a challenge right now, but most patients are at standard risk, and early treatment for high-risk smoldering myeloma. I think that when the three drug-based combination plus the monoclonal antibodies can be used in this patient population, probably we will be able to cure. So to cure means to survive without the disease and without treatment.
Thank you very much, Dr. Mateos. So the next question says, keeping in mind that myeloma is a disease which is mostly diagnosed in patients who are over 70 years old, what impact do you think it has the low participation of elder patients in the vast majority of clinical trials presented at us? And he also says, from my understanding, most of them exclude patients who are not between 18 and 65 years old.
No, so this is not completely true. So in fact, all clinical trials conducted in elderly myeloma patients usually do not have any cutoff of age. And in fact, in all trials, if you go to the Alcione trial, so I've not shown you the baseline characteristics of the patients, but 1/3 of them were older than 75. I think that this is one point. And what we are doing right now, and not only us, but I would say all cooperative groups, is that we realize that when we do a clinical trial for elderly patients with myeloma and we include patients over 65, we are including a mix of different patients population, because between 65 and 75 and probably up to 80, most of these patients are fit patients, whilst the patients older than 80 are a more frail patient population. So the next step that we are doing here in Spain, but also in France, in Netherlands, probably in almost all European cooperative groups, is to split the clinical trials conducted in elderly myeloma patients between clinical trials for elderly, non-transplant eligible, but fit, and patients for elderly, newly diagnosed myeloma patients, frail, older than 80, but candidates to receive therapy. So what we are going to do is to individualize much more the treatment, because so our experience in the previous trial, when we included all elderly patients in the same trial, was that patients older than 80 years, most of them early discontinued the treatment. So at the end, these patients were not able to achieve the benefit that we were looking for. And this is the rationale for splitting trials in elderly patients between fit elderly and frail patients. But so I in favor 100% of including all patients in our clinical trials. You have also, however, to know that always the clinical trials include, I would say, between brackets, a selected patient population, because so patients have to meet a series of inclusion criteria and they don't have to present any exclusion criteria. And it's true that some patients with severe renal impairment or with plasma cell leukemia, so with some features, are not allowed to be included in the trial. And this is true, but so this is what we usually do, and probably another different option would be to design specific clinical trials for this specific patient population. But from my point of view, this would be more difficult.
Thank you very much for your answer. So the next question is, let me just search here. Is CAR T-cell treatment possible if you had an allogeneic transplant with graft versus host disease?
Yeah, this is a very interesting question, and the answer is no yet. At the present time, you have to know that all clinical trials included immune strategies, even the bispecific monoclonal antibodies or the conjugate monoclonal antibodies, or even the trials in which daratumumab was evaluated at patients who had previously received allogenic stem cell transplantation were not allowed to be included, especially if they have a graft versus host disease. But even without graft versus host disease, they are not going to be allowed to be included in the CAR T-cells trials, at least now at the beginning. I don't know if in the near future it will be possible, but you can imagine that probably the most so the challenge is to develop a graft versus host disease, and this is probably the reason, because so for CAR T-cell, T lymphocytes of the patients have to be previously collected. So this would be a challenge, and so the answer is no now, but probably in the future. Yeah? Yeah, I don't know what happened.
Sorry, I was muted. I was speaking to myself.
Okay, perfect.
So the next question comes from one of our attendees. I think we are good on time. We can finish like in 5 minutes or so. We have a few questions.
Yes,
left.
5 minutes, because I have a lot of another teleconference at 5.
Okay, perfect. Then I will go with the last 3 questions. So it said, thank you very much for your great presentation. My father was diagnosed 4 years ago with multiple myeloma, and he has been doing good so far. However, recently he started feeling worse, and after some tests, the doctor said that he has developed some amyloid deposits on one of the kidneys. So I know some drugs that are being tested to treat also AL amyloidosis. Could you explain a little bit more on this and whether there might be some trials being run in Spain? And they also say we are based in Barcelona.
Yeah, so if they are based in Barcelona, so they have to know that the group of clinic in Barcelona are experts in amyloidosis. But probably if your father was previously diagnosed with myeloma and now the disease so evolved as amyloidosis. So I don't know what was the first line of therapy, probably a bortezomib-based combination. And if your father was in remission for approximately 4 years, now another possibility is to retreat again with a bortezomib-based combination because bortezomib in combination with cyclophosphamide and dexamethasone, so it's an excellent combination for patients with amyloidosis. If not, so immunomodulatory drugs like lenalidomide is also very effective in patients with amyloidosis. Pomalidomide is also effective in amyloidosis. And so there is going to be a trial with daratumumab in amyloidosis. And so the group of Barcelona will participate for sure. And so I don't know if with the prior history of myeloma, your father will be candidate or not. But anyway, I think that if he was in remission for 4 years, so proteasome inhibitor or immunomodulatory drugs are going to be effective for patients with amyloidosis, especially if your father has only renal involvement, because the heart is the organ more problematic in patients with amyloidosis, but kidney usually respond well, not immediately, and so they have to wait probably some months in order to see a clear response, but so usually they respond well.
Good. So in the interest of time, I will go with the last question. I'm sorry, because there are some questions which will not be responded, but so a patient says, I can see dexamethasone is still being used in most of the trials. For me, the side effects related to it are too bad to deal with, and it would be good to find a regime which allow patients to get rid of this drug. Are there any running studies which stops using it?
Yeah, so this is an interesting question, especially coming from the patients, because so you're right, and dexamethasone result usually in a lot of side effects. And the problem is that many physicians do not realize about that. And when one patient did not feel very well, we usually try to say, okay, this would be this new agent or the other new agent, and sometimes dexamethasone is the drug to which most adverse events are related with. So you know that we usually use now dexamethasone low dose weekly, 40 milligrams weekly, but it is possible to reduce to 20 milligrams weekly, 10 milligrams weekly. And so as most combinations right now include dexamethasone, and the combinations are planned as continuous therapy until disease progression, so my recommendation would be to try to decrease or even to withdraw dexamethasone in the long-term follow-up, especially if the patient is in complete response or in VGPR. So, and this is what I usually do with my patients in the clinic, because so I realize that dexamethasone is very toxic, and I prefer to skip dexamethasone and patient to continue with lenalidomide alone or with pomalidomide alone. And this is something that we have to consider. But you have to know that dexamethasone is an excellent partner with an synergistic effect with almost all combination, and this is the rationale for use dexamethasone. I would say that it's key at the beginning, but in the long-term follow-up, probably we can try to eliminate dexamethasone as soon as possible.
Wow, so thank you very much. So it seems that we have sadly run out of time. And before leaving, I would really like to thank you, Dr. Mateos, for taking some time out of your agenda, which I know is very, very tight, to lead this webinar. I would like also to thank you all who joined us today. And just remember, just a couple of two things, that the full content of this webinar will be uploaded soon to our website. And without any further ado, I suggest you to stay connected with us and follow our upcoming activities in our website and social media channels. And I also strongly recommend you to visit our member section in the website so you can connect with your local myeloma patient group in case you haven't done it yet. So we are looking forward to see you soon in our next webinar, and I wish you all a very, very good evening. Thanks again for joining us today. And thank you, Dr. Mateos.
Thanks, Alfonso, and thanks to everyone for being attending the webinar.
Okay, goodbye.
Have a nice day. Bye.